get started. I've put a lot of new things in this lecture this year because there's been some exciting, oh, but you can't see me. Oh, I see. I put new things in this that so I want to make sure, that we have time to cover it because it's actually been an exciting year for pediatric sepsis. We have a new definition and lots to talk about. So first, since I usually introduce people, I will introduce myself. We will also, here's what we'll go through today. I'll give you kind of the background on pediatric sepsis. We'll talk about the global burden, current definitions. As I said, we have new definitions, so that's very exciting. And then what are our current sepsis guidelines? And then we'll specifically dive into what it means, like what is pediatric sepsis in resource-limited settings? So barriers, challenges, like current controversies. And then I'll tell you a little bit about my work and how I'm trying to address some of those barriers, challenges, and controversies. And then if we have time, at the end, I have a whole section on how you can get involved in both global health and sepsis work if you're interested. So I'll start with my story, and we've kind of heard some career pathways so far from other speakers. And it often sounds like, when people present their life path, that it's kind of like slightly meandering, but more or less you can kind of see where you're going. So I will tell you it's not really that way, but as I'm telling you this, just know that it's somewhat of it's because hindsight's 2020, and so whenever you're telling a story in past tense, it sounds like it's linear. So I did undergraduate work. I studied abroad in South America, and it was a really great opportunity. I got to do an internship in a women and children's hospital in urban underserved hospital within Ecuador, and was very naive at the time and absolutely blown away by the health disparities that I saw, and that where someone was born really influenced everything in their lives, from access to healthcare to clean water and education. And so that really sparked my interest in global health, mainly from the disparity and inequities perspective. And so from then on, I found every opportunity that I could. And much like probably many of you, did the global health track in medical school. In residency, there's also a global health track. I did rotations abroad. I did a rotation with the Baylor AIDS Corps. I did in Malawi, was a Yale Stanford Global Health Scholar. And so just tried to find as many opportunities as possible. And then I went into fellowship in critical care medicine, and there's a required, as Kira knows, a required component of research for everybody who does a fellowship. And I wanted to do it in a global health space. And so I spent a fair amount of time in Bangladesh and studied the implementation of an evidence-based sepsis protocol. And the hypothesis was that that would improve outcomes. And I was, again, quite naive. And when we were done with the study, we found that actually it didn't improve outcomes at all. And in fact, there was some signal that it may have made outcomes worse. And so that really blew my mind and kind of set me off in this direction towards research, which I hadn't really thought about or considered before. And I view research as an opportunity to affect the lives of children broadly. So it's not just the patient that's in front of you that you're directly managing. It's the ability to develop the evidence to then influence policy guidelines, et cetera. So it's really more on a population level. And that really excited me. And I had so many questions that came from that one fellowship project that it really kind of launched my career in that research direction. After fellowship, I decided to, double down on global health, and I came to UCSF into the Global Health Sciences Master's program. And then after doing the master's, realized that it didn't give me all of the skills that I wanted to be able to really do what I wanted to do in clinical research. So I decided to do the PhD program. So I have a PhD in global health sciences, clinical research, and feel like I now have kind of a toolkit to be able to do the kind of work that I want to do. I'm currently a critical care attending, so I will see some of you in clinical practice across the street at Benioff Children's. And I have found a way to interweave my passion for global health and health inequities with the critical care work in a lot of ways. I've been a consultant for WHO, one of their sepsis consultants, and worked with USAID. We have a WHO collaborating center at UCSF, so I continue to work and support their initiatives in the critical care space. And then personally, I study pediatric severe febrile illness and sepsis in resource-limited settings, primarily in East Africa. And so that'll be some of the work I'll tell you about at the very end. So again, like, it kind of sounds like it was this linear, like well thought out. We had this exercise yesterday where we kind of envisioned where we want to go. And I can tell you this is not where I envisioned where I wanted to go. And there are many kind of like hiccups and like weird turns and like, it's really more like a maze is what I'm trying to say. And sometimes the maze is filled with water and there may be alligators in there and you may get to a wall, you might have to turn around. So my advice for the trainees who are on the call is just know that it's a meandering path. It's okay to get lost and be open to new things that come your way. You never quite know like what's going to really excite you or where your passion is going to be. So just be willing to explore those different options when they come to you. Okay, so this, I would like it to be an interactive session. So one, would like to have your cameras on, and two, I'm going to ask you questions throughout this, and I do actually want audience participation. I am very good with like long, awkward pauses. I lead a lot of family meetings, so I know how to just wait patiently until you all tell me what you think. So let's start. We'll start with an easy one. All right. So what is your favorite type of chocolate? If you can use the annotation function within Zoom, you can pick whatever icon you want. If you want to do an X, if you want to do a check mark, whatever you want. Yeah, you can circle it. See, we've got some dark, we've got some milk. No one's questioning what chocolate is yet. Every once in a while. Oh, we have one. Okay. Jasmine, not a chocolate fan. That's okay. We can still be friends. That's all right. Any other takers? Okay. Looks like we've got a neck and neck, dark and milk. No one likes white chocolate. That's pretty common. So I mentioned I did a sepsis consultancy at WHO. And so myself and my family, we lived there for 6 months. And I want you to know that while I was there, I think I ate on average 2 kilograms of chocolate every month, because that's what you do when you're in Switzerland. And the average Swiss person eats 9 kilos of chocolate every year. So I was like basically Swiss while I was there. So I love chocolate. So I appreciate those of you who also do too. Tiffany, can you help me clear this? Because I'm not able to do it with the screens the way they're shown. Just clear all. So let's dive in. We'll go through kind of the burden, again, like I said, current definitions and guidelines. I don't think I can clear these. Tiffany, are you able to clear it? You trying? I'll keep going and see if I can figure it out as well. So I'd say kind of starting in 2017, sepsis became known as, there was more attention paid to sepsis. And part of that was because the 70th World Health Assembly adopted a historic resolution that aimed to for the prevention, diagnosis, and clinical management of sepsis. The World Health Assembly is kind of the governing body of the WHO, where the WHO is the implementing arm. So this is essentially the WHO. And the WHO published in 2020 their first global report on the epidemiology and burden of sepsis. And this was one of the things that I had the opportunity to be a part of when I was at the WHO. And really what this report came on the heels of a landmark paper that was published by the Global Burden of Disease group that's out of Seattle. And so they did this huge analysis of global data. And, we had this sense that sepsis was a big problem before this publication, but we didn't have numbers to put behind it. So this is the first time that we really had like tangible numbers, and the numbers were staggering. So there's an estimated 49 million cases every year of sepsis, and 20 million of those are occurring in children. So that means 2 out of every 5 cases are happening in children under 5. So that's cases, and there's also 11 million deaths, which means that sepsis is accounting for 1 in every 5 deaths worldwide of all causes, like cancer, heart disease, trauma. 1 in 5 is due to sepsis. And of those 11 million, 3 million of those deaths are children under 5, which is the population that most of us are caring for. Not only that, but there's massive disparities on a global level. And so 85% of both the cases and the deaths are happening in low and middle income countries. And this is what it looks like. So you can immediately look at this map, and what this is showing us is deaths related to sepsis as a proportion of the total deaths for the country. And so the yellow countries are, 0 to 8%, whereas you get to the dark blue and you're talking about, up to 45, 50%, sometimes higher. This is apparent immediately, right, that there's disparities here that are geographically bound. And so sub-Saharan Africa and Southeast Asia bear the disproportionate burden of both cases and deaths, although what I'm showing you here is only deaths. So when I see data like this, my next question is, okay, so then what is causing sepsis and death in children under 5 globally? This is data also from 2017. And you can see, slower respiratory infections, neonatal conditions, diarrhea, malaria. I look at this and you kind of run down it, and almost or over 50% of them are really due to preventable and treatable infections, all of which can cause sepsis, malaria, meningitis, measles. So that's a lot. Like going back to what Raj had said in his talk, we actually know how to treat most of these things or prevent them. So then, why aren't we is the bigger question. Okay, another opportunity for engagement. So sepsis has a lot of, I would say, a lot of different definitions or meanings to people, and it depends on kind of whether you're talking in a clinical capacity or research capacity and whatnot. So I'd just like to know, again, using your annotation function, what is sepsis? Like, you hear the word sepsis, and which of these words, and it can be more than one, do you think of? What comes to mind? We've got inflammation, infection, there's organ dysfunction. Getting organ dysfunction. Does anyone think of all of them? Looks like Kira maybe thinks of all. All right, great. So I'm going to break this down because I think that there's a conceptual definition, and then there's our formal diagnostic criteria. So Tiffany, can you help me clear it again? So I'll start with the conceptual definition, and I actually really like this one. This is the Sepsis 3 definition. It's developed for adults, but because it's a conceptual definition, I think we can also apply it to children. And so it's this life-threatening organ dysfunction caused by a dysregulated host response to infection. And what I like about this is that it's not just the infection, the pathogen, it also has to do with how the host responds to that. And that's really important because people respond differently to infections, and that has huge implications for how we treat it. And that's true in any population. So I think conceptually, this is how I think about sepsis. But then what I'll say is that this was our pediatric sepsis criteria from 2005 until just a few months ago. And because it's only recently been phased out, you're going to still hear these terms until we kind of fully transition over. So you'll hear about the systemic inflammatory response syndrome, or SIRS. And so if you have a systemic inflammatory response syndrome in the setting of a suspected or proven infection, then you have sepsis. And then across sepsis, there's this spectrum of severity from sepsis to severe sepsis to septic shock. And so you can kind of think about that as the clinical presentation of severity. Now, like I said, we're transitioning away from the SIRS criteria, and there's a few reasons why. So the SIRS definition of sepsis was developed by consensus, which means that a bunch of experts got into a room and said, well, what is sepsis? So it really wasn't evidence-based. It also, we found in serial studies, has really poor predictive ability. So it's too sensitive and it's non-specific. It captured which means when you translate that, it captured too many children with mild illness and didn't reliably identify children who are at risk for poor outcomes. And that was true in high and low resource settings. In study after study, we saw that it actually did not perform very well. It also included this term of severe sepsis, which was redundant and non-informative. So like, what does that even mean? Like, you have sepsis or septic shock, but then there's this like weird middle ground. Like, what does that mean clinically? Well, do I treat them differently? So it was just like not a very helpful term. It was also difficult to operationalize like organ dysfunction. We had organ dysfunction on our conceptual model of what sepsis was, but like what does that again like really mean? And these weren't based on robust or readily available data. And it also did not include diverse clinical settings. So this was very much driven by high income countries and experts. And there are other important considerations. So, most of sepsis research has been based on an ICU population. It hasn't been based on like an emergency room population or a ward population. And we know that sepsis can happen anywhere. And 80% of the pediatric patients with sepsis actually initially present to the ED or an outpatient inpatient setting. So we're missing all of those kids. So I'm going to stop and get to different views so that I can erase things as we go. Things now. Okay, so let me go back. So as I said, so literally just like 8 months ago, we completely blew up our definition of how we define sepsis. And that came out of this international consensus for criteria of sepsis and septic shock, which is short. We have been referring to it as the Phoenix Sepsis Score. So I have to admit, so we're currently reading Harry Potter in our household, if there's any Potter fans. And so I hear Phoenix and I'm like, oh yeah, it's the Order of the Phoenix. That's really cool. It's not actually, it's actually named after the conference where they unveiled it, the Society for Critical Care Medicine. So it's named after Phoenix. But regardless, this was conducted or created after like an international survey. So this was more inclusive than the original SIRS criteria. And then they did a systematic review and meta-analysis to identify measures of organ dysfunction. As I said, like it's really hard to operationalize. Like, how do you operationalize organ dysfunction, like cardiovascular or renal? And then they did a data-driven approach, which is great. And they validated it. And they did that in over 3 million pediatric health encounters. So that's huge. For those of you who do research in pediatrics, 3 million is a lot of data. And they tried, again, to be more inclusive of sites with resource variable settings. So the sites were in China, US, Kenya, Bangladesh, and Colombia. And then they tested how well did these organ-specific scores actually predict mortality. And then finally, after they developed all of this and validated it, they essentially put it out for a consensus process to all of the experts to see if it captured the language that they wanted it to. And this is it. This is our new terminology, how we are going to start talking about sepsis. So sepsis is still this idea that there's a confirmed or suspected infection, but now you have to have organ dysfunction. Now, organ dysfunction is very clearly defined by the Phoenix Sepsis Score. There's also this new idea, they've gotten rid of the severe sepsis and added this new idea of remote sepsis, which is kind of complicated from I think a conceptual perspective, but it's essentially that you have, this organ dysfunction that is not related to the location of the infection. So a good example is you have pneumonia, but you develop hemodynamic instability. So the hemodynamic instability is the cardiovascular system, and that's your organ dysfunction. But the primary site of the infection is actually pneumonia. So that's remote sepsis. It's still kind of like a funny, to me, kind of a concept. And then finally, you have septic shock, which is where you have sepsis and specifically cardiovascular dysfunction. So that stays. So mainly sepsis and septic shock with this idea that you can have an infection in a separate site. And when we say organ dysfunction, this is how the Phoenix score works. So 2 or more points in the categories of respiratory, cardiovascular, and cardiovascular can be whether you need support for your blood pressure, if you have hypotension, if you have lactic acidosis, or coagulation or neurologic. They actually considered several other organ systems, and there is this research-based expanded score that you can use, but they found that with just using these, 1, 2, 3, 4, 5 systems, that they were actually able to get pretty high predictive ability. So simplified it to this. So this is going forward, how we're going to define sepsis globally. And this is the proposed diagnostic workflow. So you have a child in front of you who looks unwell, and they have a suspected infection. So immediately, the very first step is to screen for sepsis. Do you think they have it? Yes. Then you go to assess for organ dysfunction using the criteria that was on the last slide. If they have a score greater than or equal to 2, they meet sepsis criteria. And at that point, you need to decide, do they have septic shock? And have take these other things into consideration. So do they need antibiotics? Do they need organ support? Do they need to be transferred? Does your hospital or clinic have the capacity to take care of them? And then quality improvement, like how do we adhere to best practices? Like we do have best practices for treating sepsis. Is there a research study that they should be enrolled in? And then how do we keep track and monitor disease surveillance and outcomes? So the other thing that I think is really nice about this diagnostic workflow is this monitor and reassess side branch. So maybe they don't meet sepsis like right now, or they don't have septic shock right now, but you have to continually reassess them. It's not one time point. And so things can change, as we know, through the course of a child's hospitalization or presentation to the medical system. So just continue to reassess and keep this in mind. So as I said, this is like brand new. It just came out in January of this year. So we still need to do future independent validation. We need to include more low resource settings. I didn't show you this, but those 3 million hospital encounters were primarily from high income countries, even though there was some representation from low resource settings. It was vastly more towards the high income countries. So we need to know more about like urban and remote settings, mixed healthcare settings. We need additional testing across age groups and for special subgroups of populations, chronic conditions, those who are technology dependent, might have congenital disorders or severe malnutrition. And we need to validate sepsis and septic shock in preterm infants. So preterm infants were not included in the data set that created this score, from which they created this score. And we need RCTs to focus on, especially this subset of children with remote sepsis, because that's a new concept, and then septic shock and sepsis-associated multi-organ dysfunction. And then we need an improved understanding of that, host pathogen interaction, and specifically, how does that relate to organ dysfunction? And so there's, move towards multi-omics, phenotypes, endotypes, and using big data to understand like the pathophysiology behind sepsis. And testing novel clinical and molecular markers so that we can discriminate the children who need antimicrobial therapy and decrease AMR. And so we had a couple of lectures yesterday about the importance of AMR. So we need to be able to figure that out fast. The things that are in orange are things that I and the people I work with are actively working on, and specifically in low resource settings and subgroups that are important or more common in resource limited settings, like those who are malnourished. I won't have time to go into all of them, but we'll touch on some of them. Okay, so we have this new definition for sepsis, but what about guidance and guidelines? So I'll say in early 2000, there was a group of experts that came together and they formed the Surviving Sepsis campaign, and they published the first guidelines for how to manage sepsis. These were mostly adult-based recommendations. Every once in a while, there would be kind of like a pediatric consideration, but this is driven by adult providers and mainly for treating adults. And so that's what we had. Every 4 years or so, they update the guidelines and look at the new literature. And until 2020, what we had was trying to adapt adult guidelines and apply them to our patient population. But then, like I said, 2020 was a big year, like between 2017 and now, like a lot has happened in the sepsis world. And in 2020, they published pediatric specific Surviving Sepsis campaign guidelines. So I'll say there's a lot of recommendations, 77 statements of recommendations. Most of them are similar to adult guidelines, with the exception of fluid therapy and prophylaxis. But most of the recommendations are weak, which means that they aren't supported by strong evidence. So it ends up being a lot of like consensus, expert consensus. And most of the recommendations are actually based on adult literature and data. And that's why, like, we just don't have the PEDS data to generate our own guidelines. And they call this out specifically to their credit that the recommendations are intended for emergency department and ICU management from high income countries. And so they say that this is driven by data that's been generated in high income countries and really is only applicable there. So then, that leaves us with, what are we supposed to do in low income countries or resource limited settings? So it turns out, and I actually didn't know this until I was working with the WHO, that the WHO does not have sepsis guidelines. They're actively working on it. And that was part of what I was doing when I did my consultancy, but we got derailed by COVID. So hopefully they'll come out within the next 12 months. But the closest thing we have for pediatrics is the ETAT guidelines. I don't know if you all have seen this. It's the Pediatric Emergency Triage Assessment and Treatment. And so it's essentially based on like priority signs or warning signs. And then so helps providers identify what those warning signs are and then leads them through care pathways, airway, breathing, circulation, mental status, dehydration. And so you can see how sepsis could have multiple different warning signs and lead you down one of these pathways. The other tool that we have for pediatrics is actually the American Heart Association, the PALS algorithm. For those of you who are really, newer to practice, sepsis, the septic shock algorithm wasn't always incorporated into the PALS teaching, but now it is, and it's because it's such an important clinical condition for children in particular. And so you'll see in your PALS card that there's actually a specific pathway, an algorithm for septic shock, sepsis and septic shock. Okay, so that's our burden. We talked about our definitions, we talked about our guidelines. Now let's talk specifically about sepsis and resource constrained settings. So before the Global Burden of Disease study came out in 2020, the biggest kind of pediatric epidemiologic study we had on sepsis came from the Sprout group, Global Epidemiology of Pediatric Severe Sepsis. And they estimated 8%, an 8% global prevalence of severe sepsis in pediatric ICUs globally. This was in 126 pediatric ICUs across the world. They also estimated a 25% in-hospital mortality rate. I'm going to pause there. That means 1 in 4 children who have severe sepsis die in a hospital globally, which is really high. Like, what else can you think of that has that kind of a mortality for kids that you're seeing in the hospital? So this is a really big issue with high mortality. Interestingly, they didn't find any difference between high and low income countries. But there's a few caveats to this. So one is that the countries that participated, many of them actually weren't representative of probably the entire region. So a good example of that is South Africa was the only country that was from sub-Saharan Africa. It also importantly, kind of harkening back to what I said before, it only included children who were in dedicated pediatric ICUs. And so for those of you who've worked in other locations, pediatric ICUs are not universal. And so if you need that to be included in a study, you're already excluding arguably the most vulnerable population. So this is what we had beforehand. We undertook a large systematic review and meta-analysis to understand the causes of hospital mortality in children in low and middle income countries. We did it was a massive undertaking and had a huge number of papers that ended up meeting our criteria. But what that meant is that we had a huge source of data. So this study represented over 21 million pediatric hospital admissions from 293 sites in 59 low and middle income countries, and included 6 of the global burden of disease super regions. So you can see the countries that were included. The white countries are countries that were not low and middle income countries, so shouldn't be included. And then those that are blue and purple contributed data. And one of the things we found was we looked at the cause of hospital death by diagnosis, both globally and by region. And so you can see that sepsis and septic shock was the 5th most common cause of death globally. And then you can see it's like Latin America, North Africa, South Asia, Southeast Asia, and Sub-Saharan Africa in the columns. But that's just if sepsis and septic shock were the final diagnosis. And I would argue, going back to our conceptual model of sepsis, that any infectious disease related death, the final common pathway is sepsis. So malaria, pneumonia, meningitis, gastroenteritis, HIV related illnesses, and measles, like all of those, the final common pathway is sepsis. So I actually think that of the top 10, it's the majority of them are sepsis. And then I work primarily in East Africa, and Tanzania is where one of my main sites is located. And if you think about the burden, in contrast to kind of what the Sprout study found, where there's no difference in outcomes, I think about the population that I study, and more than 20% of that population lives in poverty. The majority of them don't have access to improved sanitation or a water source. And there's very few physicians, as 0.1 physician per 10,000 population. 5 out of every 100 children will die before the age of 5, and that's 7 times greater than in the United States. It's also one of the top countries with the highest under 5 deaths. It's more than 100,000 every year. And now, thanks to the Global Burden of Disease study, we know that 1/3 of all deaths in Tanzania are related to sepsis. And this is a picture from the oncology ward at Muhimbili National Hospital, which is the site for my primary study. And just kind of looking at it, and this is a question for all of you who've also worked internationally and in other settings, like, what are the challenges and barriers that you can think of for managing pediatric sepsis in similar settings? You can type it, you can come off mute.
Antibiotic resistance, like materials for placing IVs, or just staff in general for vitals and stuff.
Yep, staff in general, that's a huge one. We think a lot about resources, resource availability as being like physical things that we have, but also we need to have people who can treat the children and that they're trained to be able to do that. What else?
Infection control.
Right.
Is a huge problem.
Huge, right? You don't want to give additionally, you don't want to spread infections within the hospital. Yeah, being able to have the time, the process. So is there a pathway? Is there a bundle? Yeah, things are crowded. Delays in presentation, access to care are huge, right? Like if they never make it to the hospital, that's actually a really hard number to estimate, because they don't reach care. They die before they get there. Yeah. Diagnostics, I totally agree. Lab services. So all of this goes into like the health systems perspective, the training, personnel, and the availability. And so I kind of distilled it down into what I thought was kind of the biggest challenges and barriers. And this is, very simplified, and most of you have touched on some aspect of this. So I think adding to it too, being able to identify sepsis rapidly and accurately. And this is actually a real challenge, again, globally. And we know that this is one of those time-sensitive conditions where we have to act fast, the golden hour. You have to get antibiotics in quickly, because antibiotics after a certain time point in some studies beyond 3 hours, you see this sharp increase in mortality. So it matters, like speed is important, and you have to do it. You want to identify the right kids, right? And then having the resources to treat sepsis appropriately. And then I added this third one, which is, again, not specific to resource limited settings per se, but it brings up, again, because most of our data is coming from high income countries, but like knowing how to treat sepsis. If we think about, again, like that this host and pathogen interaction is really what's driving sepsis, then both what's infecting people and the population that's infected have a really important role to play. So you can't just like plop guidelines that were developed at, San Francisco down in Dar es Salaam and expect them to work. And that's what we had tried to do in Bangladesh, and it didn't. So we need to know the best way to treat sepsis for that population. So going back to our new and shiny Surviving Sepsis campaign guidelines, these are pediatric guidelines, and I picked out a few key things. These are things that, we do commonly at Binyap Children's Hospital for children who have sepsis, especially in the PICU. But can you circle things on here that you think might be particularly challenging to do in a resource limited setting? Yeah, so monitoring, source control, right, could be dependent on, do you have a surgeon who can drain that abscess? Yeah, how do you have the clinical and laboratory? Maybe even having appropriate antimicrobial therapy. Yeah, renal replacement therapy is definitely not universal. Nitric oxide, also highly specialized, very expensive. Maybe there isn't mechanical ventilation or treatment for ARDS. ECMO is super specialized, right? Definitely. agree with all that you said. And obviously, I cherry picked the ones that I knew were the hardest. But yeah, I highlighted some of them, which were the things that you guys identified as well. So we have these guidelines, but like, what does it even mean if you don't have the resources to do it? So the WHO has their own guidelines, and I said I was going to get into the controversies, and I think one of the biggest controversies in pediatric sepsis management is about fluid management, and this is the ETAT, the original ETAT guidelines, which are from I think 2000. And you can see that it parallels what the PALS algorithm was. So it's 20 milligrams per kilo as fast as possible. And then keep going, 10 to 20, keep going, another 20. And you're supposed to do all of this like within an hour. It's pretty quick, as rapidly as possible. And so this controversy comes from, there's data from US pediatric populations that aggressive early fluid resuscitation, even if it's started by community providers, can decrease mortality. And this came from one of Joe Carcillo's studies that if the child got more than 40 mLs per kilo within an hour of presentation, they had improved survival. So we're like, oh, that's great. Like we need to be doing this aggressive fluid resuscitation. And they also saw in that study that if you didn't fluid resuscitate enough, then those were the kids who had the highest risk of death. So everyone was like, oh, we need to fluid resuscitate these kids. We need to do it fast and early. But there's mixed evidence when you start to look beyond these more well-resourced health systems. So in Brazil, there's a study that shows that rapid high-volume fluid resuscitation within an hour does decrease odds of mortality. But in Colombia, just next door, if you got early rapid fluid resuscitation, the group that received more early rapid fluid resuscitation had less respiratory failure. Wait, I think it's the other way around, where they had more respiratory failure if they got fluid early on, because that parallels what happened in India. So what they did is they essentially gave the same amount of fluid, but they gave it over different rates and over a different amount of time. And the children who got rapid fluid resuscitation were more likely to have respiratory failure and require intubation as compared to those who had gotten slow resuscitation. So it's like, what are we supposed to do then with fluid? Like some places it seems to be good and helpful, and others it actually seems to be harmful. So this was the largest, this is another landmark paper, New England Journal of Medicine, 2011, so it's old now, and some of you may not be aware of it, but when it came out, like it was like shockwaves through the pediatric critical care and resuscitation world. So this is the largest multi-center trial that we have in fluid resuscitation in children, and happened to be conducted in African children with shock, and it was over 3,000. The children are randomized to receive normal saline, albumin bolus, or no bolus at all. And I've seen the first author present, and this was meant to be a head-to-head comparison between normal saline and albumin. And at the last minute, they added this third arm of no bolus. And that ended up being it would have been a negative trial with no difference, but because they added this no bolus arm, what they found was that regardless of what the bolus was, normal saline or albumin, if you got a bolus therapy, you had earlier reversal of shock, which is great, that's good news, but you also had increased mortality. So the relative risk of death for any bolus was almost 1.5. And they saw that this excess mortality associated with fluid bolus was consistent across all subgroups. So if you had malaria, if you had a coma, if you had anemia, acidosis, it didn't matter. It seemed like bolus was bad for all of them. And that's again, our mainstay of PALS therapy is fluid resuscitation. So why is it different here? And so there's lots of different hypotheses as to why this could be different. So one is this idea that there's reperfusion injury. So essentially you're resuscitating too quickly and causing a sterile inflammatory process on top of the overwhelming sepsis inflammation. Maybe there's myocardial dysfunction because you have a worsening acidosis associated with the sodium chloride, or there's capillary leak third spacing, especially in patients who have a higher prevalence of anemia, malnutrition, so their albumin is lower at baseline, malaria positive as well. It causes increased third spacing, especially if it's p-valcipram. Or maybe it was fluid overload, we're just doing too much. So they have, cerebral edema, respiratory failure, myocardial dysfunction. And all of these things, maybe we have all of these things here as well, but because we can rescue kids, we don't actually pay attention to it. So if they get fluid overload, we just intubate them or we put them on dialysis and they still survive. But in settings without those resources, maybe the fluid resuscitation is more harmful without the rescue available. So I'll tell you, we don't know the answer yet. We're working on it. There's been a few other follow-up studies, and I'll tell you about one here, which is trying to get at like what the core problem is. So this was a post hoc analysis of that same study, and what they did is they asked different pediatricians to independently review the cause of death, or like the underlying like reason for death. So not sepsis, but like, did they die from respiratory failure? Did they die from cardiogenic, which meant essentially shock, so hypotension? Was it neurologic, which in this case it was defined as elevated intracranial pressure from presumed cerebral edema? And what this is showing you here is that the top line are, if whether you got any bolus or saline or albumin, the highest rate of mortality or cumulative incidence of mortality occurred in the children who got a fluid bolus and they still died of shock. Can you see that top line? So this is really interesting, right? Because I also told you a few slides ago that the children who got boluses had early reversal of shock. So they have shock, we give them fluid, the shock gets better, but then it gets worse again, and they're still dying from shock. So this is really interesting, but it also shows us that they're not likely dying from cerebral edema, from fluid overload, nor are they dying from respiratory failure, the children who got boluses, also probably not due to fluid overload. So just adding more to the controversy of what's going on here. So as I said, we don't know the answer, but I want to ask you all, like, given these data on fluid resuscitation, the mixed data, the feast results, the post hoc analysis, would you change your practice for fluid resuscitation and sepsis? You can use your annotation. Okay, we've got some yeses. Got 2 people. Others? And Jasmine, because you're going into PEM, so this is going to be, you're going to resuscitate kids who have sepsis. How is this going to change your practice?
To be honest, I'm so early in training, like I question everything, and a lot of the things we learn don't like, even just between like 15 cc's bolus and 20, like there's no rhyme or reason, it's just preference. So I question everything, and this is enough. Convince me.
No, that's good. Actually, it's a really good like way to approach these things. Like there's a lot, like understanding the data behind like the reasons we do things. Sometimes there is no data. Sometimes the data is flawed. This is really good. You should question it. So this isn't a trick question. I can tell you for personally myself, the answer is yes and no. So I will say that in in San Francisco, again, where we have dialysis and intubation, I still follow PAL's algorithm, do aggressive fluid resuscitation, again, because I know that I can rescue the kids if we overshoot. Now, if I'm in a resource limited setting where I don't have the backup of an ICU, I do change practice, and I don't recommend aggressive fluid resuscitation. And I'll say that this actually did change the practice broadly. Puppy in the background. She wants to be part of this. So I showed you the WHO ETAC guidelines. And after this study, the feast trial came out, they reanalyzed or rethought about how they should do this. And so children who are not in shock, who have, and they define shock as 1 to 2 signs of impaired circulation, should not receive rapid infusions of fluid. They should only get fluids. And then they should be prioritized for assessment and then be reassessed in 1 hour. Then for children who are in shock, so you have to have all 3 signs of impaired circulation, then you give them 10 to 20 mL, but you give it over a longer period of time. And then this idea of like reassessment, coming back and seeing, do they need more? Did we actually push them into heart failure? Is key, like that reassessment piece. And there's some caveats here. Like if the child has severe anemia, then you transfuse first before you bolus them with massive amounts of fluid. And so that's here as well. And it even trickled, I guess, came down to the American Heart Association, and they revised their statement in 2015. And so now, for those of you who've just taken PALS, this is the current guideline. So even though IV fluid administration is a cornerstone of therapy, For children with febrile illness in settings with limited access to critical care resources, do this with extreme caution. Individualized treatment and frequent clinical reassessment are emphasized. So this was huge. Like one study out of East Africa really changed the way that we think about fluid resuscitation. And that includes in our Pediatric Surviving Sepsis campaign guidelines. So in health, they have two separate kind of branching points for fluid and vasoactive management. And so you have septic shock, and then you can see they branch it into those healthcare systems with intensive care versus without, and how do you manage it? And specifically, again, about fluid resuscitation, and kind of mimics what the guidelines or recommendations are from ETAP. The other thing to know is like, how do we operationalize this? So I'm a member of a Society of Critical Care Medicine Task Force on Sepsis and Low Resource Settings. And we're doing a needs assessment as well as a literature review and focus groups to evaluate like what is current sepsis care, and then identify the resources that are required, and then to develop tools and implementation resources. And there's this idea, again, that there's this time-sensitive component of sepsis treatment, and that it's not just like a single point in time, that is actually kind of this continuum of care. So first we need to recognize it early, then we have to promptly activate, medical services, get them early antibiotic and, appropriate fluid resuscitation. If they need critical care, how do we get them to that? Source control. And then finally, there's also like, we forget that after someone's had, a serious infection, there can be morbidity associated with that. So how do we do post-sepsis care and follow up? So it's really just kind of this entire continuum of care for sepsis. Now I want to tell you a little bit about my work, and I just want to frame it with the big picture that I go into when thinking about this, and is that the optimal management of pediatric sepsis is very dependent, highly dependent, in fact, on contextual setting and the patient population. And hopefully, like I've kind of driven that home up till now, that both of those things are key and very important. So identifying pediatric sepsis patients at high risk for mortality. We did this study in Tanzania. We screened almost 10,000 children and enrolled over 2,000 over the course of the year. And it was kids that were outside of the neonatal range up to 14, because that's when children kind of become adults in this health system. They presented to the emergency department at Muhimbili in Dar es Salaam, Tanzania. And then because we didn't have the Phoenix criteria at the time, we defined sepsis by clinical SIRS criteria. And so that meant primarily abnormal vital signs. So we didn't have any lab-based criteria to make it more relevant to the setting. And we captured 203 in-hospital deaths. Many of those were actually in the emergency department, and the rest were on the wards. There was not a PICU at the time at Muhimbili. So that means in-hospital mortality of about 11%. And this is all comers. So this is sepsis, severe sepsis, septic shock. It's still very high, 1 in 10. And there's clinical scores that have been designed specifically for resource-constrained settings. So the question again is like, how do we identify these kids that are at highest risk for death, and how do we do it quickly? And these are, here's 3 scores that have all been developed and validated in resource-limited settings. And I wanted to test how well that these scores work to identify kids. Again, if we use one of these scores, we say this kid's the kid that I need to really focus on, then I can change the clinical pathway, put them, in the high dependency unit. I can change how the kid is monitored. And what we did is, and we tested the clinical scores specifically in how they predicted mortality. And so this is the area under the receiver operator characteristic. And so, where 50% is a coin toss and 100% or 1 would be a perfectly predictive score. The 3 scores that I showed you actually didn't perform very well in this cohort. Really we'd want them to be at least above 0.8 and ideally above 0.9. And so they really just didn't do what we were hoping they would. And so what we're currently trying to do is create a combined clinical signs and point of care test clinical prediction tool so that we can enhance this. So it's probably some combination, hopefully, of signs and tests that we can do easily at the bedside that will make this better to identify those kids. The other thing that we realized is in doing this, that again, going back to what Michelle said, is that diagnostics are severely limited. So how are you supposed to treat an infection appropriately if you don't know what the infection is or even where it is? And so these are the diagnostics that were done in this observational cohort to try to identify the source of infection. So, a pneumonia for a chest x-ray. So of those chest x-rays that were done, 71 were positive. So it's about 31%. You could test for malaria, you could do a blood culture to look for bacteremia, urine culture to look for a urinary tract infection, or an LP to look for meningitis. And if you combine all of these different ways that you could try to identify the source of infection, a source of infection was only identified in 10% of these patients. And, you know, thinking about our like sepsis bundles where you're supposed to do a blood culture within an hour and then start antibiotics, only 22% of the kids were actually getting any microbial culture. So that means that the source, diagnostics were limited, so we couldn't identify the source. They also weren't performed very regularly, and when they were performed, they weren't very sensitive. So it wasn't really guiding management or therapy very well. So the next question I had was whether we could use biomarkers to try to identify children and separate those who have malarial sepsis and non-malarial sepsis. So you can think about this. We use CRP and procalcitonin quite often in high income settings in the emergency department, PICU, oftentimes to guide management or distinguish severe from mild febrile illness. In resource constrained settings, however, clinicians often are limited to the physical exam. And then you add on that many of these resource constrained settings are actually in malaria endemic regions. And for those who have seen severe malaria present, it actually presents very similar to sepsis. And in fact, because it's an infection, it can actually cause sepsis. So you have this like very interesting like Venn diagram of overlap. But they have very different treatments potentially, right? So we did this as a secondary analysis of a cohort of children with, it was a combination of kids who had fever and healthy controls. And of those children who had fever, we categorized them as having sepsis or not having sepsis. And then within those groups, whether they had malaria or not. So we ended up with 4 distinct clinical groups. So those without sepsis, but with malaria, those with non-malarial fever, those with sepsis, we thought due to malaria, and those with non-malarial sepsis. And again, using the similar kind of clinically based SIRS criteria. Now what we did is we measured pro and anti-inflammatory biomarkers at the time of presentation. Like, could we again kind of categorize these groups based on their inflammatory profiles? And the short story is that and again on this is just one of those inflammatory biomarkers, IL-1 beta, that we measured. And then here again, you see your 4 groups: the malarial fever, non-malarial fever, malarial sepsis, and non-malarial sepsis. And you can see that there's significant differences in biomarker concentrations across the illness groups, right? Non-malarial sepsis is the highest, is the most elevated. But malarial fever and malarial sepsis had essentially the same profile. And non-malarial fever, non-malarial sepsis resembles non-malarial fever in all aspects, except for this biomarker that I'm showing you. So while there was differences across the groups, what we found was that it's being driven by the presence of malaria or not. So we did not identify a sepsis-specific biomarker profile. So the search continues essentially. And then, as I said with the last study, what we want to know is if there's a combination of biomarkers and clinical signs that can actually improve our prediction. And so this is the area under the curve for both an individual and combination of biomarkers and signs for predicting sepsis. And what performed best, this highest curve, is the one that combines the IL-1 beta, which was the most predictive, with Ang2, and then a marker for malnutrition and then malaria status. So if we had those 4 things, we'd actually get to an area under the curve of 0.77. Again, we wish that it would be a little bit higher. I think there's room for improvement, but still did better than many of the clinical sign only severity of illness scores. And then I'll just touch on this quickly. The other piece of sepsis is of accurate management or correct management of sepsis is knowing what the child has. And there's so many different barriers to being able to identify what that is. And this study is the preliminary study that we're basing our current study on. And we are using this next generation sequencing to identify the pathogens that children have. In this study, it was a group of febrile children, and they had at least 1 microbiological sample collected, including blood, nasopharyngeal swabs, and stool. Of the kids that were tested, 13 were smear positive for malaria. And then my mentors did this. They extracted RNA, did metagenomic next generation sequencing, and then pathogen identification. So next generation sequencing is this innovative kind of broad pathogen detection technique where you take a patient sample, and if there is any DNA or RNA, depending on what you're extracting, that's left over from any pathogen. So it could be viral, it could be just fragments of bacteria that are left over from bacteremia. What you do is you then pull that out, you transcribe it, you sequence it, you create this library, and then you essentially put that library and compare it to all known sequences for pathogens. It's actually not just pathogens, it's any microbe. There's a lot of like bioinformatics that happens on the back end. You have to take out all of the human DNA, you have to take out all of the junk, all the RNA as well. But in the end, what you get is this microbial identification. And so if you identify a pathogen in a space like the CSF where there shouldn't be any bacteria, then you think you probably have the causative organism for meningitis. And what we found here, what I'm showing you here is the most common pathogens. So each column is a patient, and then each row is a pathogen. And even though only, I think, 13 or 18 kids were smear positive for malaria, it actually was the majority of the kids. So you can see this is color coded where the darker purple is increased copy number. So you can think about that, it reads per million. So that's kind of like a heavier or brighter signal. There's caveats to this because there's definitely like submicroscopic malaria and questions as to whether that's pathogenic or not, but all of these children were febrile. And most of them, this was the only pathogen that was discovered. But the other thing that's really interesting is that most of these are viruses. So these kids don't have bacteremia. What they have is viral sepsis. And same thing with the nasopharyngeal swabs, lots of rhinovirus. So they have the same, and RSV. So it's the same things that we actually see quite commonly here. I'll skip this and just say, so then what we're currently doing and what we'll be wrapping up this year is studying both the etiology as well as biomarkers in a cohort of children who have severe febrile illness in Tanzania. And we're going to use kind of these novel technologies and combine that with both what we can do here at UCSF as well as what we can do at the bedside to see if we can really shed some light on on what the cause is and how best to identify the kids who are at risk in this population. And just end on, there's lots of ways to get involved. If you're interested in sepsis, there's an annual World Sepsis Day. They have free lectures and workshops and things to participate in. The WHO is currently working on their sepsis guidelines. It should be out this year. SCCM is developing sepsis guidance and tools. As I said, I'm on the task force for the resource limited setting component of that. And there's lots of pediatric sepsis trials that are currently ongoing, fluid resuscitation, etc. And then here's, for those who are interested in sepsis and also in global health, there's so many different things to be involved in. So for example, AAP has a section on global health that you can join. CUGH is a good conference to go to network, share your work. There's the World Federation for Pediatric Intensive and Critical Care. I, of course, am biased to that because I'm a critical care physician. Global Sepsis Alliance. And then the Pediatric Academic Society also has a Global Societies in Pediatrics Across Networks. It's a relatively new group. It's about 3 years old. But global health is kind of gaining, I guess, interest in some of the non-global health conferences. There's a lot of people that contribute and participate in this work. Would not be possible without all the mentors and collaborators. So just a huge thank you and shout out to everyone who's been part of this. So we have like 1 minute, so I pretty much timed it perfectly so that you can't ask any questions, but you all know how to find me. So if you are interested, I'm happy to talk about any part of this more. You can email me, we can chat in person. Oh yeah, and there is a survey link in the chat. If you could please take a few minutes and fill it out. We really do honestly look at it every year and change our program based on your feedback. Okay, 11:30 on the dot. Thank you all. Really appreciate your attention and participation. Bye.